mentioned if the heart is beating too fast, it won't have time to accumulate the blood. So the faster the heart rate, the less problems or the more problems we're going to have, because we're not going to be able to accumulate enough blood to send it all out the way that it's supposed to, so that the lower extremities can get the blood, right? And so when we have cardiac issues, that's why we eventually have problems with our valves and in our feet, right? And we can't get perfusion to happen to our toes. People lose toes. People have ulcers. They can't heal because it's further away, right? We didn't have enough blood to accumulate, and when it was pumped, it was such a little amount. By the time it got to the extremities, it was too little to do its job, right? So that's important there. So then we think about the stroke volume. So the stroke volume is the amount of blood pumped by the left ventricles in one compression, right? Stroke volume is the volume of blood ejected from each ventricle due to the contraction of the heart muscle. So the stroke volume has to do with how much blood is coming out of the ventricles. And I always say, like, the ventricles are, atrium is important, but the ventricles are super important, so much so that they have to designate certain terminology just for it, right? Just to see how much blood is coming out of the ventricles, they have a stroke volume, okay? Then we talk about, okay, remember we mentioned, like, okay, well, how does the body know that that it doesn't have enough blood, or it's pumping too much, or it has, it's not working properly? Well, the heart has what we call baroreceptors that are sensors that can feel if there's too much or too little fluid pumping through it. And they're located in the aorta, right? So when the heart pumps, the ventricles, the left ventricles pumps its blood through the aorta, there's a stretch that happens to aorta, or not a stretch, and the body says, oh, you have too much fluid, or you have too little fluid. And then it can signal its mechanisms to either retain the fluid or produce or find a way to increase the fluid, right? So this goes into the RAS system, right? The angiotensin 1 to angiotensin 2, which is going to become a vasopressor, which is going to cause blood vessels to shrink in size and cause more fluid to stay back. Or it causes vasodilation, which is going to cause more blood to be let go. That's going to get to the kidney. Eventually, you're going to pee it out. Or it can also cause aldosterone to increase, where now it's a salt. Water follows salt, so we have more aldosterone. So we're going to accumulate more salt, which means we're going to have now more fluid. So all of these things are triggered by those baroreceptors, because they're the ones who are going to signal the kidney to do the antidiuretic hormone, or to have the aldosterones increase or decrease, right? The baroreceptors do that because they're the ones in control, or who can take note how much fluid is flowing through them, okay? So we mentioned the antidiuretic hormone, right? It helps, it influences the blood pressure indirectly by regulating vascular volume. And when we get to hypertension, we'll talk about other things that can affect blood pressure, right? So we know in here with the antidiuretic hormones, that influences blood pressure by the vasodilation or relaxation, right? Or vasoconstriction. Okay. It also increases the blood volume, right? When we decrease antidiuretic hormones, that increases diuresis, right? So again, when we get to other problems that we will see, like the hypertension, we will see that's the reason why they give a person antidiuretic hormones, right? Because they want them to get rid of the fluid, right? So all of that matters. Okay, so when we get to thinking about the cardiac cycle and output, when we think about perfusion, that's our main goal. We want there to be enough blood, enough fluid that is coming out of the blood, so that by the time it gets to the toes, we have a little bit left there that's going to bring nutrients and oxygen. So we have to get enough cardiac output, okay? So the cycle so the amount, when we think about ejection fraction, the amount of blood pumped out of the ventricles over the total amount of blood in the ventricles, right? So the amount of blood that leaves the heart when the ventricles contract during systole. Under normal conditions, there is always some residual blood left in the ventricles. This is why it is a fraction. So ejection fraction is the amount of blood that is remaining behind, right? And that's important to know, right? Because if we have more blood that is remaining behind, that means we have less blood that is leaving. So they measure the blood that's going out, but they also measure the blood that stays behind, because that will tell us if we start getting an accumulation of blood being left behind, what's going to happen to the heart. It has to now start accommodating for that extra amount of fluid, right? Which is then eventually going to back up to wherever it came from, or it's going to cause the heart to stretch in order to keep that fluid in place. Okay, so the ejection fraction is important for us. So then let's talk about some factors affecting cardiac output. Okay, so we already mentioned the heart rate, which is beat per minute. So how much the heart is beating per minute. Okay, and we also want to look at preload. So preload is the volume of blood the ventricle is able to hold during diastole. So when we think about the value of blood the ventricles are able to hold. And notice everything is about the ventricles, right? Because they're the ones who are doing the bulk of the job. So how much blood is the ventricle able to hold is called preload, okay? So when you think before it leaves, right? So afterload is the tension developed by the heart during contraction. So afterload is the pressure that the heart must work against to eject blood. So we have the preload this is the amount of blood that we are accumulating right before, right before it is sent out. So that's how I think about it. Preload, how much blood can the heart take right before it sends it out, right? And afterload is how much pressure do I have to put on this blood in order to get it all out, okay? And then the contractility. The contractility is the myocardial contractility, and it represents the innate ability of the heart muscle to contract, right? So the heart, yes?
I'm sorry, so preload is a volume and afterload is a pressure?
Yes.
Okay.
Yes. So preload is the volume of blood the ventricle is able to hold, and afterload is the tension or the pressure developed by the heart during contraction, okay? Right, so then the myocardial contraction affects the contractility, right? So how is the heart able to contract? So the muscles of the heart, if they're not working properly, we're not going to get a good contraction. So when we think about all of these things, we start to understand what the medications do. If the problem is preload, if we can't get enough blood to sit inside the ventricles before they pump, the medicine's going to have to work on that. Right? If we can't get enough pressure to push the blood out, medicine's going to work on that. If we can't get a good contraction in order to get all the fluid out, medication's going to work on that, right? So all of this tells us what it is that can be broken, if it is at all, okay? So all of the things we just mentioned were the systemic circulation, right? How blood is circulating from the heart to the body and the problems that can happen. Now, for it to do this circulation, it needs electricity, right? And the electricity is the cardiac conduction. It needs a signal to tell it when to contract, right? How fast to contract. And this is where the cardiac conduction occurs, right? So we have the SA node, the AV node, the bundle of His, the bundle branches, and the Purkinje's fibers. And they are located strategically so that they can work in those areas, right? So the SA node, as you notice, is right at the top where the atrium is, and it signals both atria, okay? And so what it does is it initiates the signal. It is the pacemaker. It beats from 70 to 100, right? So the SA node is the main pacemaker that initiates each heartbeat. It is located in the junction of the superior vena cava and the right atrium. The SA node generates electrical impulses at 60 to 100 times per minute and controlled by the sympathetic and parasympathetic nervous system. So what causes our heart to beat? The SA node, right? the other nodes will come in because it then sends a signal to them. They pick it up and continue it, right? If we don't have our SA node, we will have our AV node, and it will send a signal, but we'll see that it beats at a different rate, right? But the SA node is really important because it initiates everything. And it mentions that it works with the parasympathetic and the sympathetic. And if you remember what that was with our fight and flight, right? So the thing that makes our heart beat fast when we're scared, when we're anxious, when we're ready to run or fight, or what do? It's the SA node. It signals that sympathetic stimulation, hyper, I gotta fight, I gotta do something, I gotta run, I gotta think, I gotta work, right? Or after all of that is done, it also calms it down, the parasympathetic. It helps it to relax so that it can get back to its normal rate, okay? Now, we'll learn when you get to other classes like quarter 4 and 5 that there can be ectopic other signals out here somewhere. When a person's heart beats faster than it should, sometimes there's a problem with the SA node, but sometimes there are other places that are picking up signals, right? And they can obliterate those. But our main place, the place that we function the best with, that knows its job the most, is the SA node. So then we have the AV node, right? The AV node now is located at the lower aspect of the atrial septum. It receives electrical impulses from the SA node. If the SA node fails, the AV node can initiate and sustain a heartbeat rate of 40 to 60. And when you think about 40 to 60, 40 is really low, but 60 is not as bad, right? When you think of a person who's exercising well, usually their heart is around, 70, 60, because they're able to get good contractions because they were able to exercise their heart, right? So the AV node can sustain life. Now, for a person who is not as fit or as well, then it's not a great substitute because, obviously if you're not contracting as much as you can, or you should, and the oxygen is not getting to certain extremities, the person will get weak, they'll feel fatigued. Those symptoms will come about because the heart is not beating at the rate that it could have to be able to sustain the cells the way that it should, or it was made to, because the heart is made to be 60 to 100. That's where it's able to thrive best. So when it goes to 40 to 60, it manages, but not to its best, right? Then we have the bundle of His is the next signaling stop, where so SA sends to AV and AV sends it to the bundle of His, and it's a continuation of the AV node located at the interventricular septum. It also extends to the left ventricle. Then we have the Purkinje's fibers. They are the diffuse network of conducting strands located beneath the ventricular endocardium. So as we can see, once the heart sends a signal, the whole heart must contract because of the connecting factors that one sends signals to the next, it contracts this area. Then the signal comes here, it contracts this area. And it does it with one full sweep. The heart has a system that's called all or nothing. Once that signal comes out, everything contracts all at once to make the heart function properly. And if there's any break anywhere, which we'll learn about why a person needs to have a pacemaker, we're not going to have a good conduction, and that's not going to be a good thing, okay? So usually when a person have a pacemaker, right, they're going to have it up here to help the atrium contract, or they might have it over here to help the ventricles contract, right? Or they can have both that helps both the atria and the ventricles contract, and we'll see that later. So here's a little video. Again, let's see if it works. No, it does not. I don't know why it never works.
Hit it with a hammer.
I always try it before and it works, but it doesn't work here for some reason. Okay, so this is a video that explains action potential, right? If you remember in biology, back when we talked about neurons, right? They mentioned, okay, so how do I know if I put my hand on a hot stove to remove it? The signals come from the brain all the way down to the hands, and then the hand lifts up. So that signal came from the tips of the fingers and it traveled. It's the same idea with the heart, right? The signal comes from the SA node and it has to travel throughout the whole heart in order to make that contraction happen. And what's happening is the calcium, you can't see it, but the calcium and potassium are shifting from outside to inside, and that's what the potential is. So for my purposes, that's not something I'm going to test you on, but the idea behind it is important because when we take calcium channel blockers, they affect muscles. They're going to affect the muscles of the heart. You understand why, how important that is, right? Because the calcium affects how the heart functions, how it contracts. If it contracts, how it contracts, okay? More of movement of ions that allow for contraction to occur in the heart. So from phase 4 down to back to phase 4, it's a revolving doors kind of cycles each time. Okay, so now let's really quickly talk about, okay, so we said the SA node, the AV node, they send signals to the heart, right? And they do the contractions. Now, when we think about how do we pick up these signals, how do we identify if there's a problem, it's with an EKG. And this is one of the ways that we can identify if the heart is contracting properly or not, right? So we have the P, Q, R, S, T. They each tell us something different, right? So the P tells us about the atrial systole, right? We said systole means what again?
Squeeze.
Squeeze, contraction, right? So atrial contraction happens with P. So when we look at P, anytime we see a P, it tells us something is happening or not happening with the atrium. Okay, so P means atrium. But what is it telling us? It's telling us that there's a contraction there. So if we see a hump, we say it's a contraction. And what they call it with this system here is depolarization. So atrial depolarization is this P. So depolarization is the same thing as contraction, is the same thing as systole, okay? So the P wave indicates atrial depolarization. The P wave occurs when the sinus node, also known as the sinoatrial node, creates an action potential that depolarizes the atria, right? So we said SA node initiates. We said that SA node is located in the atrium. So it makes sense that when there's a signal that tells the atrium to contract, to cause systole to happen, that is in turn, when we talked about the ions, influx in and out, depolarization, right? So this is atrial contraction, atrial depolarization, okay? Then we have the PR interval. So the PR interval is a segment, it's a portion of the EKG from the end of the P wave to the beginning of the QRS wave. It follows atrial systole and proceeds to contraction of the ventricle. So if this is atrial depolarization, the atrium needs time to repolarize, right? So then that means atrial repolarization will be diastole, okay? So then atrium needs time to, it just contracted, it sent out all the blood, now it's gonna need time to refill again. So this is the time that it's going to take to refill again, okay? Now, the next one, QRS, right? That is ventricular depolarization. And we said depolarization is the same thing as what again? Contraction, right? Depolarization is contraction. So this means that the ventricles are doing what? Contracting, right? So QRS, when it looks like this, it's contracting properly, right? This is the shape that it looks like when the ventricles are depolarizing, when they're contracting. Which means, right? So let's see if anything else I need to say about that. No. Okay, so which means this segment, the T, would then mean what? What would this mean? If this meant that this was repolarizing and it was right after the P, and then this one would be what, since it's right after the QRS? repolarizing. So this is the diastole. This is the time that it takes the heart, the ventricles to repolarize, to diastole, to fill back up, right? And so this is what that is. So now we said again, we're going to see the P, the depolarization, the atrium, when it has problems, we're going to see the atrial problem here. Something is going to be wrong with the P. And because we said atrium is not as problematic, it's not strong enough when it has a problem to affect QRS. So the way that I allow, what allows me to recognize it is anytime I see a problem here and this looks normal, I know it's an atrial something. And we'll see that later, right? Now, but because we said the ventricles are so powerful, if something goes wrong with them, they mess up the whole thing. So when there's a ventricular issue, it is strong enough to mess this up too. And half the time when something's wrong here, you don't even notice this because it's so problematic, okay? So anytime you have an atrial problem, you'll be able to identify QRS. But anytime you have a ventricular problem, you won't be able to identify the P, okay? Okay, so here's a list of things to remember. The PR segment from the end of the P wave to the beginning of the QRS wave, PRI from the beginning of the P wave to the beginning. So you can read through this, right? So for my purposes, the most important QRS, right? Now, one thing I can tell you about Q wave is the Q wave is affected when you have an MI. So when you have a heart attack, right, you're going to have a dip in the Q wave, and it's going to be there forever. Anytime you go to get an EKG, however long from the 10 years, 5 years that you had this heart attack, they'll be able to tell because your Q wave will be there'll be a dip in it, right? Then we have the ST. That's another thing to take note of. Those of you who are going to have patients, or maybe have already had patients in clinicals that have ST MI, non-ST MI. So again, when you get to quarter 4, you'll see this more, and because we don't cover MI in this class, but the thing to remember when you see ST, non-ST, it's like, okay, how do you remember which one? So usually, and that's why they have to indicate non-ST elevated MI, because usually when you have a heart attack, ST is elevated. And the way I think about that, I'm like, elevated is, you gotta get help now, elevated, right? Whereas the ST that's depressed is an angina. It's like, we already know the problem. Just take nitroglycerin and you'll be fine. Go sit somewhere, right? So it's like, don't worry about it. It's depressed, right? But elevated is, we have a problem. It's an MI, right? So just for future references, when you get here, right? This tells us if you're gonna have an MI or not, or if you have had one, okay? So now back to cardiac conduction. We've already mentioned atrial depolarization is our P wave, okay? Then we get repolarized here. Then the QRS is our ventricular depolarization, that's contraction. And the ventricular repolarization is the T. Now, this is also important when we think about, measuring them, which we'll see in our next class, right? These little boxes, one large box is 5 millimeters. One large box is also 0.20 seconds, right? So lengthwise and widthwise, right? And so this will tell us how to identify in numbers, right? So I always say the same way when we talked about acidosis, right? We had the words about acidosis, if the person is hyperventilating, or if a person, has, certain issues, like how do we identify with words? And then we also have the numbers, like if they gave us labs, how to identify it. It's the same thing here. when we talk about, you know, ST depression, or if we are talking about AFib, right, we can say, let's say VTAC, we would say wide and bizarre. Those are the words that identify VTAC. But we can also say the QRS is greater than 20, right? So there are numbers and there are words that identifies each problem. And this is just the numbers. Now, for me in my class, I'm not going to ask you to measure, but for NCLEX, those numbers are important. So as you get further on in your courses, you will see the numbers become more important. For me, I want you to be able to look at it and grossly be able to identify, oh, this is AFib by the characteristics of the wave. Now, can you learn, which we will learn, how to measure it and how to identify numbers? We will learn that in the class, right? And we'll learn that in our next preceding class. Let's see, anything else that we want to say? Okay, so more on the measuring, right? So here's what we were talking about, the PR interval, 0.12 to 0.20. So anything that takes longer or has a problem, we know PR is going to be atrial issues. QRS, the duration, 0.08 to 0.10. Anything greater than that, we're going to say the ventricles have issues. And then the QT and the RR interval. Mostly, the focus is usually on these two. Okay, so remember these two, and we can commit to that to memory at a later time. But okay, so let's talk about some modifiable factors that affects perfusion. So what are some risk factors that affect perfusion? So we have lifestyle. What are we talking about when we say lifestyle? Exercise, yes. So walking, pumping iron, running, right? We have cardio activities that help strengthen the heart. And what is it helping it do? It's helping it to contract, relax, contract, and the more that it is able to do it, the better it's able to do it. So a person who doesn't exercise, like me, my heart rate is like 90, right? Like 97, maybe hitting 100, I don't know. But a person who lifts weights, who exercises, who runs, their heartbeat is like 60, right? 70 something. What that means is it takes my heart more work in order to perfuse my whole body. Whereas a person who's used to exercising, it takes their heart less work. They have less beats to do the job that mine needs more, right? Because I'm not used to stretching or exercising my heart muscles, okay? So lifestyle is important. Hypertension, we're going to talk more about that with a whole class where we think about, okay, higher blood pressure is problematic because it's straining the blood vessels. And when we strain blood vessels, we can damage blood vessels. And when we damage blood vessels, we're damaging blood vessels everywhere, eyes, heart, kidney, liver, and that's a problem, right? And we're going to learn that that's a silent killer. You don't even know it's happening until it's done, okay? Then we have hyperlipidemia. So we talked about atherosclerosis. That is how the coronary arteries are being affected, right? Because of bad eating habits, right? So the thing about that too is this bad habit, like when usually do people develop bad habits?
Early on.
Early on, childhood. So this problem starts early. A person can have atherosclerosis or problems with their coronary arteries as early as 15, right? Have you seen in the news like a basketball player, football player, they're in the gym or they're playing a game, collapse. And you're like, what? They're so young. Well, from childhood, they've been eating poorly, not doing the great thing with their body, and it accumulated. Now, here's the thing. A person who's young, do they usually make it? They don't, and we're like, but they're so young, how did they? But a person who's 60, 70, they have a heart attack. I survived a massive heart attack. You're like, what?
Third one.
A third one. And the reason why is, while the heart is being damaged this way, while the blockage is being created, the body has this mechanism where it says, you know what? In a couple of years, this area is not going to be perfused anymore. So it builds what's called collateral circulation, where it starts creating additional pathways in order to feed that area in the future. So a person who's 20, do you think they would have finished building or constructing that new pathway? No. So once that blockage happens, there's no oxygen getting to that area. Death is immediate. Whereas a person who's 60, they've had years to build collateral circulation. So when the area does get clogged or blocked, they have another pathway and they survive it, right? So this whole idea with hyperlipidemia and why it's a problem, right? That's why we're going to use statins and things like that in order to decrease our buildup of plaque, okay? Obesity, too much work for that area, for the heart, right? To circulate, it's much more surface area, so it's harder for it. Diabetes, we said kind of same thing as hypertension. It affects all the arteries everywhere. And what is it doing? It's causing tortuous arteries, right? So arteries are supposed to be smooth muscle, right? The blood vessel is a circular, it's supposed to just roll down the path and travel along without any hindrances. But with diabetes, like we mentioned with the exfoliation, like we have sugar in a fluid. If you want to scrub your face, that could be an exfoliant. Same thing, if it's inside your blood vessels, it's doing the same thing. It's sloughing off skin and causing lumps and dips and whatevers. And so now the blood can't roll as smoothly as it used to, and it gets clogged or stopped or blocked so that the lower extremities, they don't receive oxygen the way they should. And it happens in every place that has arteries. Every place in our body has arteries. So we have those problems there because of our arteries. And then the stress, we mentioned sympathetic, parasympathetic, right? That initiates the SA node. Fight or flight. My heart starts beating faster. My eyes, shrink so I can see better. All this. Now, if I do that 100 times a day, one of the things they say about, I always say this, but, for African Americans, right? African American males have the highest risk for heart attacks. And the reason why is the amount of stress African American males go through, right? Just leaving the house at times. The stress of, am I going to be stopped? Am I this? I go to this. Like they have so much pressure on them. The stress of it is what causes them to be more at risk for hypertension, more at risk for heart attacks, right? And so the same thing, if a person is being abused or poor lifestyle because of, mistreatment, they're more at risk for having a heart issue, poor problems, they're the ones who, I gotta smoke a cigarette because I'm so stressed, right? That idea is going to cause problems, and it's because of the stress. Alcohol intake, same kind of issue. Alcohol can lead to tachycardia. Too many episodes of tachycardia can lead to heart failure, right? So the whole idea is the stress that's being placed on the heart, okay? And we're gonna stop here. Our time is up, and we'll continue Wednesday.